Our next speaker is Susan Stuart, one of our nurse practitioners who's spent the earlier part of her career down at UVA in Charlottesville, and then also was in Northern Virginia for a while. We've lured her across the Potomac to DC. She actually serves as the nursing director of the MS Patient Center Specialty Practices, Dr. Tornatore already mentioned. So Ms. Stewart's going to tell us about MS relapse.
Can you hear me okay? Okay, good. All right, so let's start with the definition of MS. Multiple sclerosis is a chronic, inflammatory, and neurodegenerative disease of the central nervous system, or the CNS, and that includes the brain and the spinal cord, also the optic nerve. It's characterized by recurrent relapses of CNS inflammation ranging from mild to severely disabling. So let's look at the CNS to get a better idea of what's going on. On the far left, this is a nerve in the central nervous system. You can see that's the cell body. It serves as the command center for the nerve. And then to the right, branching out, are dendrites. Those connect the nerve to muscles and organs and bring information to the nerve cell. And the bottom to the right is myelin. You can see is the little yellow coverings of the nerve fibers, and that's how this information is conducted. Underneath the myelin are the nerve fibers, which are the axons, and they take information from the nerve cell and to other nerve cells in the muscles. Now, in MS, your white blood cells, the T cells specifically, they are there at the top where they belong in your bloodstream. The purple lining you see there is the blood-brain barrier, and that's protective. It keeps bad stuff out of the brain, the central nervous system, the spinal cord. But when these T cells are activated in MS, they're able to cause inflammation and cause disruption of that barrier. It allows the T cells to get into the CNS and cause all kinds of havoc, causing the inflammation where they're attacking the myelin. Above, you see the healthy nerve cell, and then below you see where the myelin's been damaged. And the myelin can be repaired. Sometimes, though, the myelin is damaged to the point where the underlying nerve is damaged as well. And we can see this on MRI. And when we send you for an MRI, we're getting a lot of images. It gives us a lot of information. One of the images is called a T1 weighted image, and they show these dark, hypointense areas. And they're thought to indicate areas of permanent damage. Sometimes you've heard black holes. T1 with gadolinium is contrast. When we give you contrast into your vein, then it is able to light up areas of active inflammation. The gadolinium is a big molecule, and it shouldn't cross the blood-brain barrier, but if it does, then we know there's inflammation. That blood-brain barrier has been disrupted. And then we also have a T2 weighted lesion, or images that shows the burden of lesion load, meaning the total amount of lesions, both old and new. And there's also FLAIR. That also gives us more information specific to MS lesions. And FLAIR is also very helpful with spinal cord imaging as well. And I'm showing you can see the white spots there on your brain MRI from the side. That's one of the dark holes. There's more than what I've pointed to, but unfortunately there'd be a lot of arrows on this lady. And then the spinal cord, you can see a white lesion, which is a little more difficult to see. Now, depending on what part of the brain you have a lesion, can dictate what kind of symptoms you have. Although sometimes you can have new spots and you don't know it. You don't feel them happening. Sometimes you're symptomatic, sometimes you're not. But it might be the reason why you're having difficulty with your gait or walking or your vision, as well as with the spinal cord. In your spinal cord, the cervical and thoracic spine, if you have lesions there, that can affect your motor function, sensory, bowel, bladder, sexual function as well. And so you see these as your symptoms. These can be whole body symptoms, including fatigue. I'm preaching to the choir here. All of you are familiar with what your MS symptoms are. And we also know with MS and the different forms of relapsing MS that we see these patterns. And if you look to the far right, that's relapsing, remitting MS. And on the bottom, you can see these little purple arrows. Those are disease activity on MRI. And then the orange rectangle is a relapse. You can also tell that early in the disease process with relapsing MS that there's more frequent MRI activity and you have a relapse. The first square or rectangle there, it goes up, it comes right back down to the baseline. The second time it goes up, it doesn't quite come down to the baseline. So now you have a new baseline. That means that you didn't get back to where you were before. Now you have symptoms, you have some disability. And then you have another relapse. Maybe you get better, maybe not quite so well. So you can see it's like stairs, and the disability increases with these relapses and as time goes on. We don't want that. We try to keep that from happening. And the second part, you see secondary progressive MS. That gray rectangle is everything to the left. That's already happened. So now what we're seeing is maybe not so much activity on MRI. People are still having relapses, but the progression also increases. And then in progressive MS, you have you start off pretty strongly with disability, and it continues. And you see you don't really have relapses, even though you might have activity on your brain MRI. So we've seen that MS relapse is a characteristic feature of relapsing forms of MS. It's also what we use to diagnose you, to evaluate your therapy. And we know that the frequency and severity of relapses are variable and unpredictable. We expect you to have maybe one relapse every 2 years. And you might have several relapses in 1 year and then maybe go for years without one. We also know how this adversely impacts you. Daily functions are impaired and residual disability is common. Relapses are associated with increased emotional distress and depression. Higher relapse rates are associated with worse quality of life. Psychosocial impact of relapse is profound. It extends to the families. Social and vocational networks are affected as well. The costs of relapse are also substantial. There was a study done in 2015 on a registry of 1,000 patients that had reported a relapse in the last 12 months. And so we wanted to be able to characterize really the impact that these relapses have on patients. And we see that patients stated that most perceive their relapses as moderate in severity, and symptoms seem to range from fatigue, weakness of the lower extremity and sensory symptoms, problems with walking, and weakness of the upper extremity were rated the highest. There was also a large percentage of cognitive symptoms and sensory symptoms, which may be associated with a higher residual disability. They don't always get better, they take longer to go away. And about 46% of patients complained of dizziness, which is pretty debilitating. Most individuals suffer from multiple symptoms, not just one. So this has a huge impact on daily activities, even at 3 months after the relapse onset. And only half reported feeling better when most clinically relevant recovery is likely to have occurred. So at 3 months, we would expect you to be back to your baseline or your new baseline. The recovery would have happened, most likely. So we also found that the status, how you're doing 1 month after your relapse, also indicates how you may be doing at 3 months. Only 55% reported receiving treatment for their relapse. That's only about half. 1/3 felt their treatment had no effect or made them worse. Of the 53% who received corticosteroid treatment, which is typically how we treat a relapse, over half reported an adverse event, and 30% would rather have a different treatment for their relapse next time. More than 50% reported missing work or school, an average of 13 days. and 68% reported an impact on household tasks. 20% utilized a healthcare facility needing to go to a hospital, an ED, or an urgent care facility. So let's define relapse. It's a new neurological symptom or increased severity of an old neurological symptom that lasts greater than 24 hours. It occurs at least 30 days after the start of a previous relapse, and it cannot be explained by any underlying infection, heat exposure, fever, fatigue, or stress. So you have your MS relapse and you have your MS symptoms, and sometimes it's kind of hard to tell what's going on even for us. MS is characterized by periods of relapse and remission. Symptoms related to MS are reminders that your disease is always present. The symptoms can come and go or be constant. They may be worse with provoking factors such as infection or heat, if you get overheated or overdue, if you're fatigued, if you're stressed, if you're not sleeping well. Relapses and worsening baseline symptoms are different, usually. So how do we treat relapses? Usually with corticosteroids, Solumedrol, which is IV Solumedrol, IV methylprednisolone, and Decadron. We give you high dose, usually 1 gram daily over 3 to 5 days. It's given as an IV, and you would need to receive that in the hospital at an infusion center, or it can be done at home. We can also give prednisone and Decadron, which is also dexamethasone, an oral treatment. It can be 500 milligrams a day daily for 5 days, or we can give you a larger dose than that as well. And we can give you a taper as well. And this certainly has a lower cost and less inconvenience factor. The side effects of all steroids are many. These aren't benign drugs. That's why we are not always giving them so freely. It has to be necessary. And many of you are familiar with some of these side effects. Stomach issues, indigestion, some mood swings, difficulty sleeping, headache, concerns that we have with people develop chest pain, can cause some swelling, increased blood pressure if you have high blood pressure, increased blood sugar, if that's an issue for you. And some people are even allergic to steroids, and they can break out in hives and develop a rash. Another treatment might be ACTH, which is Acthar gel. And this is adrenocorticotropin hormone, which is something that your body makes already, and it helps to stimulate your body to make steroids. And this can be injected either in the muscle or under the skin, and it's done once a day for 5 days. For severe relapses that don't respond to other therapies, there's plasmapheresis, which is you need to come to the hospital for that. It's usually about a week-long process, and we take your blood, filter it, remove whatever antibodies or toxins may be in the blood, and then give it back to you. There's also intravenous immunoglobulin, IVIG. Again, the first course that you receive of that, you would need to receive that at the hospital. Some people receive it at home afterwards. But that is where we take human immunoglobulin from healthy donors and give that to you as a transfusion. The best thing you can do, though, is take your disease-modifying therapy. So these drugs reduce the frequency and severity of your relapses, they reduce the activity on MRI, and they reduce worsening disability. That's what these drugs can do now. So it's very important for you to take your medication. Also know that not all relapses need to be treated. If your symptoms aren't intrusive, if it's not really bothering you, it's more of an annoyance than anything else, we don't need to treat that. Even if we do, you might get better faster, but in the long run, it makes no difference in your disease course. Over time, your symptoms may improve. Many people recover without any treatment. You can only receive steroids a few times a year. And when I say that, I mean getting the 5 days in a row, 3 to 5 days. Some of you may be on steroids once a month, and that's your treatment. Frequently, relapses may mean a need to change your DMT. If you keep having relapses, maybe the drug that you're on is not the correct drug any longer, and we need to reevaluate that. So what is a pseudo-relapse? It's what you feel like is a relapse, but it's not caused by new damage, meaning there's no new spots. The symptoms often resolve more quickly. There's something called Uthoff's phenomenon, which is if you get overheated, such as if you're running or if you take a shower and your body overheats, that slows nerve transmission. And where the areas where the myelin's been damaged, it takes things longer to get back and forth from the nerve to the motor or muscle. Also infections. We treat the infections. We would not give you steroids if you have an infection and worsening MS symptoms because the steroids decrease inflammation. They decrease your immune response. And if you have an infection, you need your immune response to be robust to fight the infection. So you need to think, what are my baseline symptoms? Is this something new? Are these my old symptoms that are just worse right now? And why are they worse? What's going on? Pregnancy and breastfeeding. So during pregnancy, women are less likely to have a relapse. And we do know that the relapse rate decreases along the second and third trimester, probably because there's natural immunosuppressants and higher corticosteroid levels during pregnancy that's protective for women. 20 to 40% experience a relapse within the first 3 to 6 months after giving birth. The effect of exclusive breastfeeding on postpartum risk of MS relapse is thought to be protective. And once regular feedings are introduced, disease activity is likely to return. No DMT is approved for use during pregnancy. And when I say DMT, I mean disease-modifying therapy. No DMT is recommended during breastfeeding. Corticosteroids for acute MS relapse can be used during pregnancy. The use of prednisone in a woman who is breastfeeding should be carefully monitored, and you need to talk to your pediatrician. MRI without gadolinium is safe during pregnancy, or if breastfeeding with gadolinium, you need to pump and dump. You wouldn't want to give that to the baby. After relapse treatment, follow up with us. Come back in and see the nurse practitioner, follow up with one of the physicians. You may need, depending on how severe the relapse is, you may need rehabilitation, inpatient possibly. Physical therapy. If you've had some cognitive changes, you may need neuropsychology or neurocognitive testing. And speech and language therapy as well. Work. So you may need to reduce your work hours or take off time while you're recovering. And we know this is difficult and it's not always something that you can do, but let your manager or supervisor know if you're having a relapse. See if they'll work with you so they can arrange for you to work from home or work some decreased hours or take more frequent breaks. Under the Equality Act, if you've been diagnosed with MS, you're entitled to ask your employer to make reasonable accommodations so you can remain and work. At home, household tasks you would normally undertake are become difficult. Be kind to yourself during this period. Keep within your limits. Don't try to be Superman or Superwoman while you're trying to recover from a relapse. And ask for help from family and friends. Can relapses be prevented? Take your DMT. Vitamin D has been shown with lower levels increasing the relapse rate. So again, we like you to have a level of 60 to 80 with your vitamin D. Manage your stress. You can't get rid of stress, but you can control how you manage it. Get your flu shot. If you get sick, you will probably have a relapse, so get your flu shot. Balanced diet, regular exercise, get plenty of sleep. Don't smoke. If you do, stop. We know that smoking causes higher level of disability, greater MRI disease burden, and more frequent atrophy, which is where your brain gets smaller. Okay, thank you.